hard candy lemon drops. Let them suck on it, and that increases the salivation to push the stone out. If you can't get it out, if it won't come out naturally, then the ENTs will go through the duct opening with their little fiber optic doodads and grab it and pull it out. But that's not the preferred route. When they come into the emergency room, you just give them a drop.
What causes the stone?
It's just any glandular tissue can produce concentrated secretions, and over time they can become calcified. You see it a lot with the kidney stones, or they can become, if they're not made of calcium, they can be made of cholesterol or uric acid or all sorts of different minerals. Most gallstones are cholesterol based.
I was just wondering about like a fun fact about the hard candy. When something is like sour, how come it like burns back here?
How come it burns? Anybody else burn back here?
Like makes you pucker.
Like it makes you like.
It probably has more to do with just the taste buds, that sour is one of the principal tastes in your reaction to it.
I'll bring you some air.
Well, I don't like sour stuff. Okay. Here's a fun fact here. You're going to have lacerations of the eyebrow. Since this is the top of the orbit, this hits things first, and lacerations through the eyebrow are common. The rule of the day is never shave an eyebrow because they sometimes will not grow back. That's when you never shave an eyebrow. You just suture, if you have to, just suture the hair into the wound. It doesn't matter. This right here, these are the steri strips I was mentioning with the geriatric skin. You know, you just put those on either side of the wound and suture through the steri strips. This one right here is definitely going to need some sutures to close that up. That's the upper eyelid right here, right there. You'll be suturing these all the time in the ER. Just don't shave the eyebrows. It's kind of funny in the Impractical Jokers, one of the penalties that Murr had, they shaved his eyebrows. And I was thinking, well, that's not a good idea. That was worse than the time he was lost and had to get both nipples pierced. Here's another very important clinical tip that you need to carry to your grave. Whenever you have a split lip from bar fights and whatever, the first stitch that you put in, the first suture that you put in, or throw, is through the vermilion border. That right there is the vermilion border. And you see what this person's done right here is they've approximated the vermilion border. Exactly. And you put the first stitch there. And then you can suture in the two directions. If you don't do that, you're going to wind up with this type of heel here, and cosmetically this is not acceptable, and you run the risk of a malpractice suit. Okay? The mandible is a pretty simple structure. It has a condylar process and a coronoid process. This is the articular process, is the condylar process. There's the notch. On the inside, there's a foramen there. It's called the mandibular foramen. There's a line and a groove we don't care about. It's just where the mylohyoid attaches. But that hole there, that foramen is important. Mandibular foramen, so remember that. On the outside, we've got the ramus, which is up here. We've got the angle, and the body is here. And then part of the body down in the front is the mental foramen. So just to give you a heads up, there's a nerve that enters here. It's called the inferior alveolar nerve. It enters there and exits there. What do you think the nerve is? What's ever branch out? V3. V3. So it's inferior alveolar nerve, and mental nerve is its termination. What do you think that nerve does?
Numbs the teeth.
It's sensation to these teeth and sensation to the skin. We were talking about dentistry yesterday, where you inject right there. The dentist is trying to hit that hole. Well, not actually hit the hole, but in the area of the hole. You infuse the lidocaine, it anesthetizes, it does a block on the inferior alveolar nerve, all the teeth go numb, and your chin goes numb. So when the dentist injects you, and he wants to know if you have achieved anesthesia, what does he do? He says, can you feel that? Just, can you feel that? If you can't feel that, you can't feel your teeth. Okay?
What nerve was that from again?
V3, mandibular. All right. Sorry?
Did you say V3 just now?
It's V3,
Okay.
mandibular. Maxillary, the infraorbital, is V2. So your top teeth are at V2, your bottom teeth are V3. The mandible is held in place by a couple of structures, not only just a bunch of muscles, but by a couple of very strong ligaments on the inside. You're not going to find those. I don't really care that you know these. The point is that there's a strong ligamentous attachment to the mandible. Also, the joint, the TMJ, the temporomandibular joint, the TMJ, has a capsule around it that you see here. It's the articular capsule of the TMJ. The structure of the TMJ is, here's the condylar process, there's the zygomatic process of the temporal bone right there, that little notch. There is a fibrous meniscus or plate between the two bones. So you're not having bone grinding on bone, you're having this fibrocartilage that produces a softening. You know, it's like gristle. It's on that. The same with your knees. You have the menisci in your knees. You have the same thing up here in your TMJs. This is a hinge joint, obviously, like that, with a lot of mobility. Not only depression and retraction, but extension and retraction. Okay? And you can do it depending on, when you talk about the muscles of mastication and their function, if you contract these and relax those, you can move the jaw that way. And do it opposite, you do it that way. If you do all this stuff together rhythmically, it's chewing. It's just a coordinated chewing. And because it's voluntary, it's somatic efferent. Now, one thing about this structure here is that fossa there has on this side a little hump. And some people who either get hit like that, forcefully open the mouth, or even some people who yawn, they get a really big wide yawn and all of a sudden they dislocate their mandible. Dislocation of the mandible occurs quite frequently in the ER. And what happens is the condylar process flip in the little fibrocartilage, flip in front of that dipped part of the zygomatic process. And it can't go back over. Because as soon as it comes out of joint, the muscles around it tighten up. They spasm, and you can't tighten up. Okay? So they always come into the emergency room with their mouth wide open. This cowboy right here has dislocated one side only, so he's goofy looking. Okay? Now the way you fix this, it's really quite easy to fix it. The first thing you have to do, though, is up there where it says dislocated mandible, requires ample sedation. You gotta just knock these guys out because their muscles are so much in spasm. You versed them up, versed, it's like a Valium, injectable Valium. It relaxes you, believe me. Once you get them really relaxed, you take your thumbs wrapped with gauze, you stick it in the mouth. You don't have to worry about them biting you because they can't close their mouth. You push down and backwards, and you'll feel it just clunk. It goes back into place pretty easily. But you gotta sedate them. You gotta sedate. Most of the time, these are accompanied by alcohol on board, so it doesn't take much Versed. But now you don't want to do this until you, of course, X-ray them to make sure they don't have a fracture, a mandible, especially if it was a trauma. Every time I've had to put one of these things back in, it was always because of yawning. I've had a bunch of fractured mandibles, but never a dislocation because of a fracture. It's always yawning. Some guys just, at work, just minding his own freaking business. Oh man, it's after lunch, I had Italian food, and then all of a sudden it's like painful, and he can't close his mouth. And he can't talk. He can't lose his jaw. When you lose all your teeth, it's called edentulous. It's called edentulous, that's without teeth. There are changes to the mandible as you age if you're edentulous. And this is what happens. They lose their mass, both the height and the thickness. And the mental foramen actually, because the bone goes away, it actually moves to the top of the mandible. It's kind of weird looking. We have young cadavers, so if we were to look at them, we wouldn't see a lot of this right here going on. That 95-year-old guy probably is like this. I don't know, when you open his mouth up, if he's edentulous, you can feel his mandible, how thin it will be. Okay? The part where the teeth join the mandible or the maxilla here is called the alveolar ridge. That's the roots of the teeth stick into the alveolar ridge. Muscles of mastication, we started talking about those earlier. The temporalis and the maxillary you see right here. The two that we didn't talk about earlier are the medial and lateral pterygoids. You can see, let's go to a deeper thing. The point I want to make here is that the only one of these four that opens the mouth is the lateral pterygoid. All the rest of them close it. That's why if you jump on an alligator's back and you have his mouth, you hold his head up and close his mouth, you can hold it there because you have so little muscle mass that opens the mouth, regardless of species. The muscle mass that closes the mouth is, you try to hold that alligator's mouth open, it ain't gonna happen. Bite force is amazing. Okay, so if we look at this, so here we've removed the masseter or cut it. We see that the temporalis muscle goes behind the zygomatic process here to attach in the coronoid process, and so it's a hinge. It's going to be attached out here. It will close the mouth, depending on which fibers contract. If these contract out here and pull this forward, you can actually protrude the jaw like that. So it has multiple functions, depending on what part of the temporalis contracts. The masseter is somewhat similar. If this contracts out here, it will move the jaw forward. If this part contracts down here, it'll close the jaw solidly shut. Right here, you can begin to see the pterygoids right there. That's the lateral pterygoid right there. So in this illustration, the next illustration, we've removed the masseter completely and removed the temporalis to show you the lateral pterygoids right here. The lateral pterygoids, you see where this is running. It's running from inside the ramus of the mandible over to the perpendicular plate of the sphenoid bone. If this contracts there, then it's going to, if it contracts here, it's going to open the mouth. And that's why it works that way. Okay? Deep to the lateral pterygoid, there's the medial pterygoid right there. The medial pterygoid is just like the masseter, it's only inside the mandible. So you've got the masseter out here coming down with the medial pterygoid on the inside, sort of forms a sling to close the jaw. All right, here's our mylohyoid we saw yesterday from the outside. There's our anterior belly of the digastric right there. Okay. In this illustration here, here's our mylohyoid again, right there. Here's your tongue. There's your teeth. There's the buccinator right there. The buccinator's role is to contract to keep the food bolus centered over the teeth as you chew. It's not a muscle of mastication because it doesn't have an action on the mandible. But it does participate in chewing, mastication, because of its role. What's it innervated by? 7. Remember, not 5, it's 7. Now, this illustration right here, we're not going to do this in lab, but it's important that you see this for a couple of reasons. And where we are is deep in here. We've taken there's the condylar process of the mandible. We've taken the coronoid process off and part of the mandible here to reveal the medial pterygoid right there. Up here at the base of the skull, there's a hole. That is foramen ovale. Foramen ovale, like it's labeled with the big black letters. You need to sit next to April over there. Do you say DM or diem?
DM, like the letters.
DM.
DM.
Okay, all right.
Is that the same thing? It's like a...
No, it's like one syllable, dim. Or
Two
like 8 syllables, DM. 2 syllables, DM. Like run DMC.
That works too.
Sort of.
New nickname for the rest of the year.
So, V3, because this is the mandible we're talking about, right? V3 exits through foramen ovale. So this is the mandibular nerve here. As it comes through foramen ovale. Now, as it comes through, it's going to branch into several branches. What innervates the muscles of mastication? 5, the trigeminal. There's the temporalis muscle. There's the branches of 5 going to the temporalis muscle. There are branches of 5 that go to the masseter, to the lateral pterygoid, to the medial pterygoid. They're all associated with V3. That means V1 and V2 are purely sensory. Now here's the inferior alveolar nerve right there, which is a branch of V3 entering that foramen to go to supply the lower teeth. That's called the, there's the inferior alveolar nerve right there, entering the mandibular foramen to supply the teeth, mandibular teeth, ending as the mental nerve. This is sensory. The motor roots are up here. Just before it goes through that little foramen, it gives off that tiny little branch. You see that little branch right there? That is the nerve to the mylohyoid. So if we dissected this thing out, that nerve there is pretty easy to find, actually. Nerve to the mylohyoid. What does it innervate? And the anterior belly of the digastric. Posterior belly is innervated by the seventh grader. It's just the anterior belly. You want to right up here, right? Right in front of that is the lingual nerve. The lingual nerve provides somatic sensation to the tongue. What did I say yesterday when that dentist injects that lidocaine right there? That's where he's going, right there. And what he's using, by the way, let me just back up to show you here. Oops, I'm going the wrong direction. You see these ligaments right here? That ligament right there, sphenomandibular ligament, you can see it in your mouth, really easy. So open your mouth. Come here, come here. Can I move your tongue over? You see that? You see that ridge right there? Right back there?
In the back?
Right here, coming down the side, the back of the tooth there. That's the ligament. So what he's doing is he's just going to go between that ridge and the buccal mucosa right there, and that's where he's going to hit that foramen. Okay? It's easy. If you stick your finger in your mouth, run to the back of your bottom teeth, and over that, you'll feel medially a little rigid structure, not laterally, because that's the bone. But go either to it, you can feel it. That's the ligament. Okay, I hope nobody's filming this. So that's where you're going to put the lidocaine. So if you put the lidocaine there, I mentioned yesterday all that happens. What is it that happens when you get your bottom teeth worked on? Your teeth go numb, your chin goes numb, you drool because the nerve to the mylohyoid is right there. And what else goes numb? Your tongue, because the lingual nerve is sitting right there too. Your tongue goes numb. There's one more thing that you hit. Joining the back of the lingual nerve is that little nerve right there called the Chordae Tendineae. Chordae Tendineae. Not Tendineae, that's something else. Chordae Tendineae. The Chordae Tendineae does two things. The Chordae Tendineae is associated with cranial nerve 11. Cranial nerve 7. Remember 7 was one of those cranial nerves that had a box around it? Yeah. It provides parasympathetics to the submandibular and sublingual glands. They run in that nerve. So actually what it looks like here is here's our lingual nerve right here. Hanging off of the lingual nerve is the submandibular ganglia. But you can't see it in this illustration because it's inside, it's deeper in there. It's further down here.
What does it provide?
Submandibular ganglia. So this is the lingual nerve This is the submandibular ganglion. Here's the Chordae Tendineae right here. You've got preganglionics that started in the brainstem. Remember parasympathetics, brainstem. Preganglionics are entering through here. They're going to travel down through there, synapse, and go to the submandibular ganglion and to the sublingual ganglion. The salivary glands. Yeah, the glands that you saw yesterday, the submandibular salivary glands, that's how they get their motor innervation through the Chordae Tendineae. If you anesthetize this area, you can't produce saliva out of those two glands. The other thing is that carried over to the Chordae Tendineae is that I said the lingual nerve is somatic afferent, right? Sensation of the tongue. You have taste buds on the tongue. Taste buds on the tongue. The anterior 2/3 of the tongue, all of the taste buds are innervated by 7. The taste buds to the anterior 2/3 of the tongue are innervated by cranial nerve 7. I mentioned that when I did the organization of nerves. Posterior 1/3 is the 9th nerve. The base of the tongue is 10th. So taste is a sensation. What is the morphology of that neuron? Pseudo-unipolar. So you got to have a collection of pseudo-unipolar neurons that belong to 7, right? You got tons of taste buds. The ganglion, the sensory ganglion of 7 is right there. It's called the geniculate ganglion. We'll see it tomorrow in lecture.
I'm confused.
Right?
So taste is a special sense, right?
It's a sense. It's sensation.
I thought the special senses were the bipolar.
I said certain special senses.
Certain, okay.
Hearing, balance, vision, there's a bipolar.
Okay.
Taste is a pseudo-unipolar.
Yeah.
Olfaction is bipolar. Taste is a pseudo-unipolar. The collection of those pseudo-unipolar cells is the geniculate ganglion. So if I ask you, what is the sensory ganglion of cranial nerve 7?
Unipolar.
What is the sensory ganglion of cranial nerve 5? Trigeminal. There you go. We're on the way. Okay. What is a motor ganglion of 7? If I said, what is the motor ganglion, I'm asking you visceral efferent, because the other motor, somatic efferent, doesn't have a ganglion. So where is the visceral efferent ganglion of 7? Yeah, not the geniculate, it's the one that's a little lower down on that board right there. The submandibular ganglion.
So what goes to the top one?
This is sensory.
Okay.
That's a pseudo-unipolar. This is visceral efferent. That's
sensory ganglion up at the top.
okay. So let me ask you some questions here. Is this the last slide?
There's 2 more.
Son of a.
You've been there a lot.
Oh, no, we hit the last one already.
Oh, okay, this is easy. Just real quick. This is, I mentioned there, the termination of the external carotid, the superficial temporal, and the maxillary. The maxillary artery supplies the face. The deep facial structures. The facial artery supplies the superficial structures out here. The deep structures are supplied by the maxillary. It has an important branch right here called the middle meningeal, right there. The middle meningeal artery. You can see the maxillary artery right here. There's the middle meningeal, goes through that little hole right behind ovale. That little hole is foramen spinosum. So the middle meningeal artery goes through foramen spinosum to get inside the skull. It supplies a huge chunk of the dura. We'll talk about it, we'll see it again tomorrow. The maxillary artery comes over here and dives through this fissure here. That fissure is called it's called the sphenopalatine fissure. It's not written up there, you don't need to worry about that. But the point of the matter here is it dives through that fissure. That is entering the back side of the nasal cavity. So the maxillary artery comes through here and enters into the back of the nose to supply the inside of the nasal cavity. When I said the lateral nasal arteries off the facial are out here, but the maxillary supplies the inside, that's how it gets there, through that fissure. It's called the pterygopalatine fissure, or pterygomaxillary fissure, but the hole on the inside is called the sphenopalatine foramen. You don't need to worry about that. The point is the maxillary ends in the nasal cavity. When you're dealing with nosebleeds, this is where they're coming from, right here. A branch of the maxillary. Let me ask you a question. What do you think that nerve right there is? If that's V3, that's V2. Okay? Also, if you look on the back on this slide right here, if that's V2, notice these nerves right here going to the maxillary area. That's how V2 supplies the upper teeth. And there's like a posterior, middle, and anterior branch of V2, or maxillary nerve, and they come down through right here. So they're on the outside of the maxilla. They don't go through a hole like the inferior alveolar. You can you can anesthetize the inferior alveolar, and you anesthetize all the teeth on that side. It's not that way with the maxillary, or V2, because there are three branches. If you want to anesthetize the molars up here, you got to go up through there with that needle. If you're working on the canines here, you go here. If it's the frontal, you go right there. If you've ever had your incisors worked on, it's painful. Okay? You've had your incisors worked on? You're grinning.
Me?
Yeah.
Oh, I was a hygienist, so.
Oh, so you, yeah.
I
yeah.
do this to people.
Yeah, and it's malicious. It's
Yeah, those are the worst.
yeah.
Get ready for your nose to run and your eyes to water.
Right there. When you do work on the incisors right here, you not only inject right here. There's a little foramen on the inside. We'll talk about it when we do the oral cavity. You hit that nerve right there on the inside, and the hard palate is really stuck to there, and it's not a lot of room. And the dentist is just poking around in there trying to find that foramen. I hate this. The arteries are the same way. When you pull a tooth and it's bleeding from these superior alveolar branches of the maxillary. You notice that the inferior alveolar artery supplies the inferior teeth, so if you pull a bottom tooth, it's still a bleeding from a branch of the maxillary. In other words, the maxillary artery supplies all the teeth, or a branch of the maxillary artery supplies all the teeth. Okay, so let me go back and do this. So when you get that dose of anesthetic there in that mandibular foramen, you get a numb tongue, numb teeth, numb chin. You're drooling because of the anterior belly of the digastric mylohyoid. You also can't produce saliva from those two glands. You also can't taste on that side of the anterior 2/3 of the tongue. Because that taste goes through the chordae tendineae as well. All right? So the chordae tendineae is 7. It's running with 5. And that happens a lot. We're going to see it in other places where a branch of 7, chordae tendineae, runs with a branch of 5. It's not part of 5. If we were to section this nerve, if we were to section the lingual nerve right here, it would look like that. We'd have the lingual, and there's the chordae tendineae. So if I said a person had an injury, of the lingual nerve at the junction of the angle of the mandible with the body, which means right there, right? What functions would be lost? If you section the chordae tendineae section the lingual nerve right there, what functions would be lost? Well, already the chordae tendineae has joined it. If I cut the nerve down here, you're going to have decreased sensation, somatic afferents to the tongue. You won't have any ability to run those glands, the submandibular and the sublingual glands, and you'll lose taste to the anterior 2/3 of the tongue on that side. So if I'm running with a pencil in my mouth and I fall and jam that pencil down into the floor of my oral cavity, you run the risk of doing that. If I lesion the lingual nerve as it exits foramen ovale, what's lost then?
Could you repeat that?
If I lesion the lingual nerve right after it exits the foramen ovale, what's lost then?
Sensation to the tongue.
What's that?
Sensation of teeth?
Not the teeth.
Tongue.
Lingual. Lingual is tongue. If you eat Mexican food, lingual. The lingual is tongue. The only thing you're going to lose is sensation, somatic afferent sensation to the tongue. You won't be able to tell that coffee is hot or cold. If you lesion here, you're only going to affect the somatic afferents to the lingual nerve. If you lesion here, it's somatic afferents, taste, and visceral efferents because the chordae tendineae has already joined it. You understand what I'm saying?
When you say join, you mean like they're the same thing?
I'm sorry?
When you say they join, they like literally come together and they're the same thing?
They don't intertwine. If you did a cross section,
Oh, that's
you would see them separate, but they're still wrapped within the same, it's called an epineurium. You can't peel them apart. It runs with it. It's not part of it, it runs with it.
So that joins at the angle?
Yeah, it's right in through here.
Okay. So like you describe that as joining at the angle of the mandible?
Yeah, the ramus, the angle of the mandible is here, so that's the ramus, that's the body. So right in here, Right about in there is where the chordae tendineae is going to join the back of it. A little bit above that, actually. So if you lesion the lingual down in here, you're going to get all of it. If you lesion it high before the chordae tendineae joins it, you're only going to affect what's in the lingual nerve, which is somatic afferent sensation. Tell me where you would find synapses in a ganglion of the seventh nerve. Tell me where you would find synapses in a ganglion of the seventh nerve.
Would it be in the submandibular ganglion?
Yes, it would. It would be right there. Submandibular ganglion. Does the geniculate ganglion have synapses? No. It only has what cell types? Pseudo-unipolar. How about the trigeminal ganglion? Only pseudo-unipolar cells. No synapses. How about a dorsal root ganglion? No synapses. Only pseudo-unipolar cells. How about a sympathetic chain ganglion? Yes, synapses. Multipolar cells. Pre-aortic ganglia. Yes, synapses. Multipolar cells. Okay? We good? All right, let's go cut up some pixies.